Welcome. My name is Associate Professor Jennifer Weller-Newton, and I am the Director of the Rural Health Academic Network, RHAN, at the Department of Rural Health at the University of Melbourne. I'd like to do acknowledgement country. As we meet on many lands, I acknowledge the traditional owners and pay our respects to elders past, present, and emerging, for they hold the memories, the traditions, the culture, and the hopes of all Aboriginal and Torres Strait Islanders. In this afternoon's webinar, there will be the opportunity to ask a question through the Q&A icon at the bottom of your screen. We will be attempting to answer as many questions as possible. To celebrate Northeast Health Research Week in collaboration with the University of Melbourne Rural Health Academic Network, we bring you a webinar by Adjunct Professor Ruth Stewart. Adjunct Professor Ruth Stewart was appointed as the second National Rural Health Commissioner for Australia in July 2020. She brings to this role nearly 30 years of work as a rural generalist doctor with the advanced skills of a GP obstetrician. Ruth and her husband Anthony Brown have recently relocated from Thursday Island in the Torres Strait to Roma, and last week we're still unpacking boxes, so we are delighted that Ruth is still able to be with us this afternoon. Please welcome Adjunct Professor Ruth Stewart.
Okay, so hello everyone. I'm going to talk to you today about value-based research for rural communities. I'd like to begin by acknowledging the traditional custodians of the land on which I stand or sit today. They are the Turrbal people of Brisbane. I've come to Brisbane for some meetings. I pay my respect to the elders of this land, past, present and emerging, and I extend that respect to Aboriginal and Torres Strait Islander people with us today. So I'm just going to talk to you a little bit about the Office of the National Rural Health Commissioner, which was established on July the 1st last year. So I was appointed as the National Rural Health Commissioner. During the past 6 months, we have appointed an executive officer, Tanya Lindsay, and 2 deputy commissioners. We have Associate Professor Faye McMillan, AM, who's Deputy National Rural Health Commissioner with expertise in allied health. She was the first Aboriginal pharmacist in Australia and continues to work as a community pharmacy alongside her academic career, where she's currently employed by the University of New South Wales. My other deputy is Adjunct Professor Shelley Nolan, whose expertise is in nursing. Her other job, her main gig, is as the Chief Nursing and Midwifery Officer for Queensland. My executive officer is Tanya Lindsay, who brings to the role a huge amount of expertise in government policy and the like. So what's the role? Here's a photo of me, and on the, here we go, I think you can see my pointer, Shelley Nolan on the left there, my deputy Minister Greg Hunt, myself, and Faye McMillan on the right in Canberra at a function run by the Royal Australian and New Zealand College of Obstetricians and Gynecologists, who wanted to talk about some rural things. So our role within the Office of the National Rural Health Commissioner is to engage with rural, regional and remote stakeholders and to advise the Minister for Regional Health on rural health strategy and policy. The priorities of the office are to support urgent and emerging issues in rural health, to support and investigate innovative models of care that are suitable for rural and remote healthcare, to examine rural workforce training and primary care and engage with the reform that's being undertaken, and particularly to engage with stakeholders in rural health. So a bit of a personal story here. We're going to talk today, I've been asked to talk about research. So here's my little story. I was working as a rural GP down in southwest Victoria, and I had a bit of an argument with one of the midwives who was caring for a patient that I had. My position was that it was safe to care for this particular patient in our small hospital because we'd done it before. We knew that she would, anyway, lots of reasons. But I particularly wanted I went off to find all the evidence to back up my position. And I found that actually there wasn't evidence about rural, about the delivery of women with a caesarean section scar in small rural hospitals. I did commence a master's looking at quality of rural obstetrics. But the particular thing here was that I realised that there'd been a lot of clinical audits published of the quality of rural obstetrics, but none of that had changed what was actually happening. So I had a conversation with Professor James Dunbar, who had just been appointed as the head of the University Department of Rural Health down in Warrnambool, the Greater Green Triangle, UDRH, and he suggested that if I was wanting to do that research, I should make it part of a master's. So I began to do that. I learned some research techniques, and along the way we were developing in our small town and two neighbouring towns a managed clinical network. I'm sorry, this has a mind of its own, this PowerPoint. So my research became not just an examination of the quality of outcomes of rural maternity services. I did an evaluation of the impact of the establishment of a managed clinical network on rural maternity services. There were politics involved. The network was, let's just say, cut to the chase, and we'll say it was shafted for various reasons. And my research actually evaluated and looked at what happened and why it was that a high-performing network could be closed down. And it, along the way, became a PhD. So I suppose that was one of the things that launched me into the policy roles that I have now. Look, rural maternity care had always been a passion. I was a rural GP obstetrician and a rural girl who'd gone into medicine, and then I had 3 of my 4 babies in small country hospital. So these are things that really matter to me. Okay, let's go back now to the bigger picture, the current research environment. You may or may not have heard of the concept of seagulls. In my experience as a remote clinician, I saw lots of people flying into the Torres Strait, where I lived and worked, to do research that they wanted to do about things they were interested in. The Torres Strait Islanders called them seagulls. You know, how seagulls fly in, steal your chips and disappear. If you're unlucky, they'll drop something on you before they go. Now, locals in the Torres Strait considered researchers like that. They arrived in the community, they stole the data from the community, and they disappeared with it. And the community members never ever saw it again. There was no reporting back. It made no difference. And in many ways, the local community felt quite violated by that experience. And the research projects that were conducted were things that people living a long way away and working a long way away thought were important. They actually had very little relevance to the practice of local clinicians or the experience, lived experience of consumers of healthcare. So it really had no value to our community. And this is in a community where the health outcomes are really poor, and the clinicians and the locals have a huge number of questions that are unanswered. So it's an issue of great distress really to the local community that the research that is done isn't relevant, is done to them and on them, not with them. And on top of that, the findings are rarely fed back to the community. While I was a member of the Torres and Cape Hospital and Health Service Board, we did an audit of the results that were fed back to our communities from research that was conducted within those communities. And we found that only 2.5% of researchers reported back to the communities. I think that's appalling. It's incredibly disrespectful. I'll try and restrict what I say about it. It beggars belief, really. You ask people very personal questions, you do things to people, and then you don't even tell them the results of your findings. That's not okay. And so, funnily enough, with research being done that wasn't relevant to the lived experience or the clinical practice in the region, and that wasn't fed back to locals, that research had very little impact on the health outcomes for those rural and remote residents. And in an area that has, some of the poorest health outcomes in Australia, that becomes almost unethical, spending precious research resources for things that don't impact the health of the community that is being studied. So I put to you that researchers who live and work in a community can respond to local clinical questions. So when you're working, there are things that you go, why do we do this? How could we do this better? What is the best way to manage this condition in this community? What do we know about something? I can tell you, working in Mariba, which is a little bit like some of the Golden Valley towns. It's got a lot of orchards, except they're mango and avocado orchards. Each mango season in the hospital, we would see a huge number of mango rash. Look up mango rash in any textbook. You won't find it. It was just local law about how you treated it. Begging research. Local researchers actually understand the local context, and they conduct what we call value-based research. So research that actually has value to both the clinicians and the consumers who are involved. And the outcomes of that research are presented back to both the clinicians and the consumers in a timely manner. And the evidence can be used to influence the practice, therefore, presumably, to improve the health of that community. So, that sort of research can inform strategic interventions and can improve the health outcomes for rural and remote Australians. What not to like about that? So you, living and working where you are, can conduct research that will influence both the policy of how healthcare is delivered to your communities, and also what is done, what that healthcare looks like and why it's done. Okay, so the Office of the National Rural Health Commissioner uses research evidence to formulate policy advice. So what I'm wanting to do now is to demonstrate how the research that is conducted by rural and remote clinicians and educators can actually influence the policy that is made at government level. It can also influence a policy that is set within the teaching institutions. Your Melbourne University, for instance, wouldn't have established a rural clinical school if there wasn't good evidence that teaching students in rural and remote communities increases the likelihood that they will go and work in rural and remote communities. And that's what the government wants graduates to do. Okay, so my office encourages and advocates for support and funding of community-based research and community-based clinicians to initiate research and participate in broader research. So that's why I'm here today. And my office uses research evidence to benefit rural communities. So when I go and talk with Minister Greg Hunt or Minister David Gillespie, I will use the evidence that I see coming out in research journals to back up what I'm saying. So it's not just that I think that it would be good if we encouraged longer duration of placements for students. I say the evidence shows that the longer the students are placed in the community, the more likely they are to go and work in rural and remote communities. Look at this research from James Cook University. Okay, so designing quality community-based research. Be curious. Question. Think. What do you want answers for? Choose your research partners and mentors well. Don't just line up with the most prestigious outfit you can find, because they may just be looking for somebody who will do the number crunching and do the heavy lifting, and may not be particularly interested in teaching you the techniques you want to learn, or in addressing questions that you have as a clinician or an educator. So in that process of, sorry, I'm sharing a hotel room with my husband. Okay, so in that process of finding partners, find people who will support you and who will go with you on your journey to gathering more skills and who understand your context. Now, sometimes you can't find all of that in one person, and so you need to find several people. For example, during my PhD research, I found a very good medical doctor who understood rural issues. He wasn't particularly helpful to me in constructing my research or how I could do one thing after another. But I found another co-supervisor who was really helpful in that, so that when I was stuck, she would give me advice and help me work out what to do next. And you need to really think hard about the ethics of what you're doing. Is it reasonable to ask people to do this? Now, I have shared with you my observations of research done in the Torres Strait and how it didn't address the issues that were important to that community, nor did they report back to the community. All of those research projects got ethics approval in that they were not exploiting people and they weren't causing pain and they weren't degrading people. But the ethics of who will benefit from this research wasn't really considered. So think about that. Okay. And I'm wanting you to challenge yourself. Is my research culturally appropriate? So communication is the key. In remote Australia, in Indigenous communities, we talk about yarning. Sitting down and yarning about your research. This is a question I've got. These are the things I want to understand. Are those things that are important to you? Oh, if that's not important, what is important to you? And if you walk the path with the people you are studying and the people you are working with, you'll get much better support, but you'll also get a much better targeted research project. So communication is the key. Take your time to build rapport. It's not okay to fly into a community and leave again 2 days later. I'm sure that most of you actually live and work in the communities that you might consider studying, and I commend that to you. When there is a major power differential between you as a researcher and the community members, it takes a lot more time for people to gain the confidence to challenge you or to tell you what they think you need to know because of that whole power differential. Take that time, build the rapport. You need to have informed consent. So that doesn't just mean reading the piece of paper to the people and getting their signature on the bottom. It means ensuring that they actually understand what you're doing and why and how you're doing it. And that can take quite a lot of time to develop. And so you need to use research methods that actually empower and engage your participants. I'll leave that to you to think about, but it's, for example, in your discussion in gaining informed consent, you will be building the health literacy for people. If you design your methodology so that community members are assisting you, not only do you engage them, but you teach them skills that they can use again in the future. And you may also be interesting them in going ahead and doing studies so that they can research themselves. So once you've done your research, you need to communicate and use the findings from that. So return the data, tell people what you've discovered, whether it's that there are 25% of this community who have undiagnosed diabetes, and of that 25%, half of them already have kidney damage. That's very powerful information. And if you have engaged well with the community, they'll then be prepared to ask you why you think it's important, and they'll actually listen when you respond. So, yes, you need to present your findings to the community and the participants in ways that they can engage with and understand. So that doesn't necessarily mean that you present a PowerPoint at the local hall. It's much more likely that they'll follow what you're talking about if you actually sit down with them and have a chat about what you did and what you found over a cup of tea. You also need to share it with your colleagues and with your networks so that it's not just the local community who has studied who understand what you discovered and why it's important, but all of your colleagues and your networks understand it. And then encourage all of those people, the community members, your colleagues, and your networks to use the evidence. So I put to you, what is it about your local practice that you would like to know, but just can't find an answer to? So we've got plenty of time, and I'm very happy to take questions. I know that some questions have already been sent in,
Yep.
but we've got plenty of time.
Yep. Thank you very much, Ruth, for a really considered presentation on the value of research, and certainly the importance of being connected with community and having that community. So we do have some questions, and one of the questions I'm going to ask is in rural health research is often seen as a nice to have rather than a have to have. How can it become core business?
Well, I think it's only going to become core business when we as rural health clinicians and researchers point out that the context is very, very important in what you find, and that very often when you put a rural lens over data, you see that things are very different in rural communities. I'll share with you the concept which I find very, very helpful. It's called urban narcissism. That assumes that if it's known in the city, that applies everywhere else. Now, we all know that that is not the case. And that, really that sums up very briefly why it's important to do rural research, because just because it's one way in the city doesn't mean it's that way all across the country. And people don't understand what the differences are in rural communities. It's very simple things like, oh yes, well, we'll implement that program by getting everybody to use the internet to log in. Sorry, Minister, in my community, it would take half an hour to log in, and people couldn't be bothered and won't. Those sorts of things. And it just, it goes, I'm sure you're all thinking of different examples. So that's why rural research is really important, because we don't know what we don't know. And that's really dangerous.
It is. We've had a question just posted in the Q&A, and this is from Kari Long. thanking you for your very frank and honest presentation. And she clearly identified with many of your experiences. Kari is a board director of North East Health and a director of nursing research at a Melbourne Metro Hospital. And she's come across many ferocious flocks of seagulls, constantly swatting them away. And she's interested, Professor Stewart, in your thoughts on how to change the researcher versus site power dynamic. Often we have the participant researchers need, want. How do we wrangle this relationship so that it is mutually beneficial? She's very concerned. She's thinking of the funds and seagulls that will fly in around aged care research following the Royal Commission.
Yeah, look, I think governance is where what it all comes back to. So if you're on a board, you obviously have some governance training, and it's governance of the research project that's really important. So you need to see that there's a steering group for the research that has a predominance of the group that's being representatives in the group that's being centred. Okay, sure, if it's aged care, you are unlikely to want to have half of the committee being demented and frail elderly, but you will have some frail elderly who are perfectly capable of being on the on a governance committee. You'll also have clinicians who are involved in working with them and family members. And it's only when the people who are affected by that thing that is being studied are actually part of the governance of the research that you'll come. Now, a crucial bit in this is to get your ethics committee on board so that they begin thinking about this, and they can insist that the research that is conducted considering that aspect of the ethics, the representation, the power balance, and whether the subject of the research will actually benefit those people who are being studied. So yes, so if you're sitting in a Beechworth nursing hospital and you hear that the research team from St Elsewhere have a $5 million grant to come and study how stupid elderly people are in Beechworth, you can sit up and say, okay, so what local engagement do you have? What consumer representation do you have? If you don't hear back from the researchers, you can always contact the heads of their department, the heads of the institution that they're working with, and express your concerns. No research institution wants there to be adverse publicity about their research. We often get flummoxed, or there's a word for, we're dazed by the confidence of the seagulls. They dash in and tell us how wonderful they are. They're just different. Okay.
I suppose that for me raises a question about how important do you think it is that research these days moves more and more to co-design?
Very. Co-design, that's what we need. And even within the term of co-design, I've had people saying, oh yes, we've co-designed this. We had a consumer on our committee. That is not co-design. It has to be active engagement and an iterative process where you develop the first concept, you take it around the community, you talk it through, you do some test runs, you think about it, you come back, and you are absolutely prepared to be told that you've got it wrong.
I have another question that was sent in ahead. There are disparities in perinatal outcomes for rural women and babies continue to exist and have done for decades. What is the solution?
If there was one solution, I'm sure we would have found it. But look, I think that a really big part of it is access to healthcare, particularly access to antenatal care. I've had the privilege, I've mentioned several times, the Torres Strait and Thursday Island. I was briefly working as a GP obstetrician on Thursday Island, but was very much involved in the discussions around establishing a midwifery group practice for the obstetrics, for the maternity service on Thursday Island. That process was very much co-designed. It began with midwives saying, okay, this is something we really want to do, and the local community insisted that they be part of the design. And it took a long time. It took over 18 months of discussions and meetings and negotiation for the eventual design to be agreed to. One of the things that the community insisted upon was that all women, whatever their risk rating, all women who lived in the Torres Strait should be seen, should be allowed to be part of the midwifery group practice, and that nobody would be turned away, or nobody would be told, no, you have to go to Cairns. Cairns, by the way, is over 1,000 kilometres away, and you can't drive there. And that service has now been operating for 2 years. No, actually more than that. 4 years now. The smoking rate for pregnant women has halved. This is in a community that has, the women are 85% Indigenous. The smoking rate has halved during pregnancy. The number of premature births has halved. Last year, sorry, the year from the 2019-2020 financial year, there were no premature births from that cohort. This is in a community that had some of the worst perinatal outcomes in Australia. And I think that that relates to the relational care. The midwifery group practice is very much led by the Aboriginal and Torres Strait Islander health workers who work shoulder to shoulder and hand in hand with the midwives, and also the GP obstetricians and GP anaesthetists who support the work of the midwives. It's a collaborative effort, I think, and I think it's all about relationships. By building relationships and being trusted, the women engaged with their care and listened and responded and changed their lifestyle because they understood why it was needed, and they trusted the people who were advising those changes.
Thanks, Ruth. And it really emphasises the importance of that relational and community, and building up that network and really getting to know the community and the community.
Yes.
Yeah. We have another question, and this is from Jane Keeley. Do you think quotas for locally initiated research projects would work at rural and regional institutions to encourage local research, development, and potentially attract investment support?
I think that'd be a really good idea, Jane. I think the other thing is that for many clinicians who just wanted to get out and do the job, they come out into practice without a deep understanding of research methodology and just don't know where to start. I know during my time working at James Cook University, we would do roadshows. When we went out to a community to do clinical education upskilling, we would tack on to that some research upskilling and talk through the basic skills. We would usually deliver over a day on a weekend a module of one of the diploma research subjects, just as a taster, so that people could have a think about whether they wanted to go on and do it. I think it's about access to learning about that, understanding that it's not actually all about test tubes and white coats and, you know, lots of mathematics. It's can be very much about sitting down and talking and qualitative kind of research as well.
Yep. Thanks for that. There's another question from Susan, and she's thinking, in the context of the university sector's newly acquired skill in engaging with students online rather than in person, it would be good to enable more undergraduate honours projects and postgraduate researchers to partner with clinicians in rural settings and conduct more research that is meaningful in local communities without bringing in seagulls. What are your thoughts there?
Yeah, look, a great idea. And I'm aware that there are several medical schools that already do that. The great challenge, and I experienced this at James Cook University, is getting during the time that a student is on rural rotation, even if it's up to a year, it can be really difficult to conceive of, design and get ethics approval and then conduct a study. That's almost too much. But Susan, as you suggest, partnering with local clinicians might be the answer. The local clinicians can work maybe with a series of students to develop the research question and design the study and then conduct the research. So partnership with students, yes, is a really good idea. I find they're incredibly enthusiastic, you know, like just when you're feeling a little bit tired and, you know, maybe I just can't do this, the student will do an all-nighter and come in the next day with the thing that you thought you wouldn't get done for another month. You know, it's great.
It's wonderful when you have that energy from
yeah,
students.
Right, yeah.
Speaking of students, a question came in ahead of for you for this afternoon, and it's the question is about what research and data collection should occur in undergraduate medical education, particularly in the establishment of new clinical schools.
Okay, so what I'm particularly concerned about, and I've just been writing an editorial about it, so it's top of mind for me, is what interventions increase the rural destination of health profession students. So those are the things that I really want to know. We've got lots of answers, but we don't. There's still lots that we don't know. I mean, you know, the summary is that choose rural origin students, give them early, well-supported clinical experiences that are repeated, the longer the better, and then give them jobs that they can go to. Funnily enough, they need a job to go to become a rural clinician. But questions like, does it matter if you make them go, or do they have to want to go? We've got some answers on that, but not enough. And the questions that sort of the difference in urban origin versus rural origin students. I've just read a really interesting paper from James Cook Uni where they compared non-metropolitan intake of students and metropolitan intake of students, all educated in the same regional and rural locations, and then looked at the impact of their internship and early career, the location of those internship and early career jobs. And the absolutely fascinating thing is that those non-metropolitan doctors who had a rural early career job, internship and PGY too, that had a profound effect on their rural destination. So I think that is a particular area that we just don't know enough about. I'm conscious of the fact I was getting annoyed at my husband in the background there. He actually has had over 30 years as a rural doctor, but he grew up in the inner suburbs of Melbourne. So, you know, what is it about him that made him become a rural doctor? And I don't think it was just me. I'd love to say it was, but I don't think it was just me. Yeah, so there are lots of things, but particularly what makes a difference. And, you know, let's look at what are the negative impacts. In fact, there's very little research into what are the negative things. I could sit here, I could have talked all day about the attempts of my educators to turn me off my determination to become a rural doctor. You know, luckily I was such a dreadful student that they weren't all that interested in keeping me in the city. But, you know, and I was a dreadful student because I hated what they were doing and I could see that it didn't have relevance to the rural career that I wanted. So,
Ruth, thank you for such a really honest answer to that question. Oh, it was lovely. We have one last question. And this particular attendee has asked, thanks you for your presentation. And they were just wondering, do you have any tips on how to secure funding for research participants? And what are your views on payment for participants?
Look, the research I've done I've tended to do it on the smell of an oily rag. So I haven't participated in research that requires payment for participation. I always worry about the impact of payment on the research. I think recognition that by participating in research, you know, participants are giving up their own time and, you know, other things perhaps. But I suppose if you design your research such that it has integral value for the participants, I don't think you need to pay them. But also thinking of the power differential between the researcher and the researched, the object of research. You know, why is it that the researcher's time is paid for and not the subject of the research? So, you know, you can see that I'm a bit on the fence there. Sorry, I can't give you a you know, cut and dried. I don't think it's a cut and dried question answer.
I don't think it is either. So, thank you, Ruth. There are no further questions in the Q&A, so I think I'm just going to do a wrap up and thank you immensely for creating time this afternoon and for such a frank and honest and open presentation about the value of doing research in your local communities. And I think we've certainly got some take-home messages there to really be mindful of ensuring that we engage with our communities appropriately and that the research is with them, not on them. So
thank you very much.
Thank you.
Enjoy the rest of your day. Bye.
Bye.